Hello, everyone. Today, I would like to talk about atopic dermatitis or eczema and some updates, mainly about what we have found about correlations with other atopic diseases and eczema and treatment modalities. My name is Sherwin Hariri. I am a board-certified allergist and immunologist here in Los Angeles. I have no conflict of interest to declare related to my presentation today. Atopic dermatitis or eczema is often the first manifestation of allergic disease. This is why it's a very exciting topic for me to talk about. It's truly often the initial sign or symptom that a child or sometimes even an adult onset eczema, that an adult or child is going to develop other allergic diseases. The word eczema comes from ancient Greek and means eruption or cutaneous eruption. Here you're seeing some pictures of classic eczematous rashes. The definition of atopic dermatitis. So per the American Academy of Allergy, Asthma, and Immunology, eczema or atopic dermatitis is a chronic or recurrent inflammatory skin disease that usually begins in the first few years of life. It is often the initial indication that a child may later develop asthma and/or allergic rhinitis. You may have heard of the atopic triad, which obviously refers to the tendency of asthma, eczema, and allergies to occur together. The progression typically begins with eczema, then followed by food allergies, and then the development of asthma and allergic rhinitis. There are three key pathogenic factors in atopic dermatitis and their associated clinical manifestations. Number one, genetic predisposition. Number two, epidermal barrier disruption. And then number three, dysregulation of the immune system, both innate and the adaptive immune system. A very important lab finding in atopic dermatitis is the serum IgE level being elevated, and it can correlate with clinical measures of disease severity. Although sensitization to environmental or food allergens is clearly associated with eczema, it does not seem to be a causative factor, but it may be a contributory factor in a subgroup of patients with severe disease. Atopic dermatitis is often associated with also a personal family history of atopy in addition to the elevated level of IgE. Up to 80% of patients with atopic dermatitis or eczema have that increased serum IgE level, and often this is associated with eosinophilia. The IgE level tends to vary with disease severity, although some patients with very severe disease have normal IgE values, and that can throw us off. The clinician should make the diagnosis of AD based on a constellation of clinical features. One of the most important features of eczema, obviously, is pruritus or itch. If your skin is not itchy, it's almost impossible for this to be eczema. And then the second very important clinical feature is that chronic relapsing remitting, sometimes it is not remitting, but chronic inflammation of eczematous lesions with that typical morphology and distribution in patients with a history of atopy. These are basically essential for diagnosis. Atopic dermatitis follows this relapsing chronic course over months or years, and patients with mild disease may experience intermittent flares with spontaneous remission, but patients with moderate to severe dermatitis are rarely clear without treatment and sometimes even with treatment. The epidemiology of eczema. So AD is a genetically transmitted chronic inflammatory skin disease that affects about 10 to 20% of children and about 1 to 8% of adults. Some data say 1 to 3% of adults. In the vast majority of patients, the disease develops before the age of 5 years, although it can also develop in adulthood in as many as 20% of eczema patients. In 60% of cases, it appears in the first year of life. So patients that are newborn infants or a few months old, and by the age of 5 years, in 80 to 85% of cases. The incidence of eczema is higher in urban areas and high-income countries. In the vast majority of cases, the onset is before the age of 5. AD is slightly more prevalent in females, and persistent atopic dermatitis beyond infancy may affect approximately 50% of patients diagnosed with atopic dermatitis during childhood. One onset in the first 6 months of life does appear to be associated with more severe disease. Clinical manifestations of eczema. So pruritus, scratching, and being chronic, relapsing, or are major hallmarks of the disease. In infants and young children 0 to 2 years of old, there is a characteristic pattern of involvement of the face, the scalp, the neck, so typically neck up, and then of course the extensor skin surfaces. In older children, over the age of 2 and up to the age of 16, as well as adults, the skin lesions often involve lichenification and are usually localized to the flexural folds of the extremities. Factors that can exacerbate symptoms in patients with atopic dermatitis include temperature, humidity, irritants, infections, food, inhalant, and contact allergens, and definitely emotional stress. A couple of important clinical manifestations are listed here. So number 1, dry skin and severe pruritus are cardinal signs. 2, acute eczema is characterized by a lot of also papules and vesicles with exudations and crusting. And then subacute or chronic lesions look more like dry, scaly, and excoriated erythematous papules versus the acute, intensely itchy, pruritic erythematous papules that do have those exudations and crusting. Skin thickening from chronic scratching and fissuring may develop over time. Interestingly, when people have eczema, kids and adults, in many of those patients, you can see lesions that are in different stages at the same time. So sometimes it's very acute on the cheeks versus it is very chronic on the flexural or extensor surfaces or on the knees. Here you're seeing a picture of acute eczema. This infant has a confluent erythematous rash on his cheeks and chin, and there's some microvesiculation, there's papules, there's definitely crusting and scaling, and maybe even a secondary infection. Subacute or chronic eczematous lesions are shown in these pictures, where on the left side, looking at the dorsum of that hand, you're looking at numerous erythematous small papules that look very chronic. And on the right side, you're looking at, some popliteal fossae with hyperpigmentation and slightly scaly patches like lichenified plaques. And definitely this looks very chronic. Some special parts of the body that are definitely commonly seen with eczema are eyelid eczema and lip eczema or atopic cheilitis. Here in the left picture, leftmost picture, you see typical eyelid eczema, finely scaly pink, plaque right there near the medial canthus. And in the second picture of the eyelid eczema there, you're seeing definitely some mild periorbital edema, and you're seeing typical eczematous, hyperpigmentation, some scaly plaques, but definitely also the famous Denny-Morgan lines, which are those extra skin folds or lines in the lower eyelids, which is classic for eczema. And then on the right side, you're seeing atopic cheilitis or lip eczema. You're seeing the dryness, you're seeing the scaling lips, but definitely note the blurred vermilion border of the, upper lip. So what are risk factors for atopic dermatitis or eczema? So again, you have genetic and you have environmental. From the genetic risk factors, a family history of atopy, so a family history of eczema, asthma, or allergic rhinitis is really the strongest risk factor for atopic dermatitis, because about 70% of eczema patients have a positive family history of these atopic diseases. And then interestingly, it's a known fact that children with one atopic parent have a 2 to 3 time increased risk of developing eczema, and that children with both parents being atopic, the risk is about 3 to 5 times of the normal population who does not have any family history. We now know, we have known for, I'd say about 10 years at least, that loss of function variants in the filaggrin gene or FLG gene results in a defective epidermal barrier, and that this is a major risk factor for atopic dermatitis, but also other skin and skin diseases and allergic diseases, including even allergic contact dermatitis, asthma, and food allergies. The function of the filaggrin is to bring together the structural proteins in the outermost skin cells to form tight bundles, creating a stronger skin barrier. A loss of function of the filaggrin is associated with disruption of keratinocyte differentiation. It is also associated with decreased water retention and impaired tight junction formation, as well as an altered lipid formation there in the outermost skin cells. And, this is why eczema has the dry xerotic skin, and the integrity of the basement membrane of the skin has been compromised. And now you have also an enhanced susceptibility to cutaneous infections. Multiple other genes have been proposed as potential contributors to the risk of atopic dermatitis as well, including genes involved in the regulation of innate host defenses and T cell function as well, but there's a lot of research going on for that. The environmental risk factors are obviously climate and urban versus rural setting, where urban settings, again, are a risk factor. Air pollution, early exposure to non-pathogen microorganisms, and also the water hardness seems to play a role. And if the water is hard, you're potentially at higher risk, and this may influence, all of these may influence the risk of eczema. The well-known hygiene hypothesis, so there's actually 2 systematic reviews providing evidence to support an inverse relationship between atopic dermatitis and exposure to endotoxins, early daycare, helmet infestations, number of siblings who bring home all the bugs, and farm animals, pet dogs, etc. in early life. And we know, though, that there's no protective effect associated with viral and bacterial infections. So alteration of the cutaneous microbiome is a well-known association with eczema. So most patients with atopic dermatitis do have a change in the skin microbiome with reduced diversity and definitely overgrowth of Staphylococcus aureus. A meta-analysis of 95 observational studies has found that 70% of patients with atopic dermatitis carried S. aureus on lesional skin, and even 39% carried the S. aureus on the non-lesional skin. Patients with eczema are predisposed to the development of bacterial and viral skin infections, and because S. aureus colonizes nearly 100% of patients, impetigo in lesions with atopic dermatitis is very frequent, and associated actually with disease exacerbation of eczema itself. Infection with the community-acquired MRSA is uncommon, though, among children with atopic dermatitis. And therefore, MRSA treatment is typically not necessary. Eczema herpeticum, or Kaposi's verruciliform eruption, is the rapid dissemination of herpes simplex viral infection in the affected skin of patients with eczema. And eczema herpeticum is a rare complication occurring in less than 3% of patients with atopic dermatitis and can occasionally be recurrent. Severe eczema, high levels of severe IgE, and history of food allergy or asthma appear to be a predisposing factor. So let's now talk a little bit about food allergy as a major association with eczema. So first of all, the prevalence of eczema, again, has increased. When you look in studies from the 90s, so 1997 to 1999, the prevalence was about 7.4%, and that went up to 12.5% in 2009 to 2011 on the National Health Interview Survey. So these data were all reported by the Quad AI in their recent report from 2022 that I examined for most of this information. And there's also no doubt that the prevalence of food allergies has increased. Rates of food allergy diagnosis in the outpatient setting, in my own clinic, in ER visits for food allergy, and hospital food allergy related discharges have all increased for sure. It used to be about 3.4% again in the late 90s, and now it's about 5.1% in 2009 to 2011. So again, if you look at eczema increasing, the prevalence of eczema increasing, as well as food allergies increasing, there is a link there. 20% of children with eczema are known to be allergic to peanuts, egg whites, sesame seed, in comparison with only 4% of children without eczema. 1-year-olds with eczema, we know, are 6 times more likely to have an egg allergy and 11 times more likely to have a peanut allergy. So remember this, a 1-year-old who has eczema is not, double the risk, it's not quadruple the risk, it's 6 times the risk of egg allergy and 11 times the risk of peanut. That's huge. And again, those compared to those without eczema. And this is just highlighting that AD, or atopic dermatitis itself, seems to be a risk factor for food allergy. The rate of food sensitization, again, is much higher in someone who's, let's say, 3 months of age, 3 months of age even, like again, 6 months, and not just even 1-year-old. Food allergy in adults with AD is much less well studied. Wheat, milk, and then the birch pollen related foods like apple, carrot, hazelnut, celery, etc., which are part of the food pollen syndrome, have all been associated with atopic dermatitis in adults. The link between food allergies and atopic dermatitis is definitely there. We don't know what immunologic mechanisms link the two, but we think that through the cutaneous route, people are getting a lot of their initial sensitizations. The amount of environmental peanut allergen exposure in living room dust increases the risk of peanut sensitization and peanut allergy in children who have eczema. And in addition, filaggrin is an important protein in the epidermis, right? And that is also not only associated with allergic dermatitis, but also food allergies. Based on several studies, it's been found that the Staph aureus, eczema, and food allergies are all associated. So we see that, first of all, one, the transepidermal water loss is increased in food allergies patients, so even non-lesional skin. Then we know that there's reduced filaggrin breakdown products, which is associated with immature skin barrier. And then 3, we know that type 2 immune activation with in the immune system is found in also the non-lesional skin of children with AD and food allergies. And then 4, there's an increased abundance of Staph aureus compared with non-atopic controls. Most of you have heard about the LEAP study, the Learning Early About Peanut Allergy study, which was major in recommending early introduction of peanut instead of waiting until after the age of 1. And we know that in the LEAP study, S. aureus colonization was significantly associated with eczema severity, and S. aureus colonized kids were more likely to have persistent egg allergy and peanut allergy independent of their eczema severity. So the authors in the LEAP study speculate that S. aureus may potentiate peanut allergy, or S. aureus may inhibit tolerance mechanisms during peanut consumption. More studies are needed to understand this whole interplay of AD, skin barrier abnormalities, S. aureus, food allergy, and the whole type 2 immune activation. The sooner eczema starts, the more severe, well, first of all, so the more severe eczema is, the sooner eczema starts and the longer it persists. And we know that food removal in AD may promote immediate food allergy symptoms in as many as 13 to 20% of participants with AD. So Chang et al. Are stating that in their study, 19% of children diagnosed with food-triggered AD converted from no history of immediate reaction to immediate reactions after eliminating the food. And the whole new updated recommendations here are that you have to really make sure the patient needs to have the food elimination, because approximately 30% of children developed anaphylaxis to the food on re-exposure, illustrating that potential harm from food elimination may outweigh the benefits. Other children who had a history of immediate reactions developed immediate reactions to new foods after elimination. 91% of children with moderate to severe AD were sensitized to at least one common food allergen, with over half of those reporting acute clinical reactivity to a food. Negative skin tests and or negative specific, serum specific IgE testing is usually sufficient to exclude food allergies. Therefore, current guidelines recommend oral food challenges after dietary elimination to really confirm the diagnosis. So let's talk a little more about, food elimination, food allergy, and eczema. So overall, we know that egg, milk, and peanut are the most consistently implicated food allergen triggers in AD. Egg was implicated in AD exacerbations, peanut reactions more likely immediate. So patients who cut out eggs may have less eczema flares. Testing for other allergens such as tree nuts, fish, and shellfish is often also considered by allergists because of the high allergenic potential of these two foods. However, when you do testing only because of atopic dermatitis, results can be difficult to interpret in the setting of the eczema, because the predictive values for specific IgE levels are pretty good in immediate reactions, but specific cutoffs for patients with food-triggered eczema versus immediate hypersensitivity are not known. And in addition, depending on their AD status, these patients often already have very high levels of total and specific IgE, and they may have false positives. Even after skin prick testing or IgE testing, an oral food challenge may be needed in really confirming a food allergy in these atopic dermatitis patients. Although avoidance diet may lead to improvement of the eczema itself and the eczema control and severity, again, the risk is that you can develop anaphylaxis to the peanut or the egg that you're now cutting out for control of the eczema. So the dual exposure hypothesis suggests that oral tolerance to food antigens is promoted through high-dose oral exposure, whereas food sensitization and food allergy are promoted through lower dose cutaneous exposure, particularly with inflamed skin. So a couple of other things that are really important is that, oral food challenge failures describe a failure rate of 13% in patients with AD who remove a previously ingested food that did not provoke immediate clinical reactions previously. So, and then together, these studies suggest that oral exposure promotes oral tolerance, whereas removal of tolerated foods, particularly in high-risk patients, may increase the risk for immediate IgE-mediated food allergy symptoms. In addition, food elimination has serious potential for nutritional deficiencies in the very young, and elimination of food allergens can lead to essential macro and micronutrient deficiencies, feeding difficulties, in addition to poor growth. We also know from studies that patients with eczema who were on avoidance diets have demonstrated reduced growth velocity, poor weight gain, especially as the number of sensitized food allergen avoidance was increased. And we know that treatment of eczema begins with education and addressing the skin barrier with optimal skincare, including use of topical steroids when needed, and addressing potential barriers such as steroid phobia. A recent retrospective study in infants less than 12 months, basically of age, found that early aggressive use of moderate potency topical steroids, followed by maintenance of proactive therapy, was associated with decreased food allergy diagnosis just by treating the skin. Complexities of food allergy and eczema. So again, the take-home message here is that due to increased sensitization to foods in atopic dermatitis and due to a lower specificity of skin prick testing and IgE blood testing to foods, there is a growing concern that acting on these false positive results or potentially false positive results by avoiding a food could actually lead to developing a true allergy and or nutritional deficiency. There have been multiple reports of children with atopic dermatitis on elimination diets where the reactions to the eliminated foods become more severe over time, up to anaphylaxis. For instance, in my clinic, I often see kids and sometimes young adults where we say, okay, you know what, the elevated IgE is indicative of severe egg allergy or peanut allergy, and we recommend avoidance, and the avoidance really often, not always, helps the eczema, and the eczema becomes from moderate to severe to mild to moderate, or even mild. Or a lot of infants who were introduced to these solids, as soon as you eliminate eggs, the crusting of the bad acute eczematous skin on the face goes away completely. But then when you're doing that, parents should know that there is possibly an increased risk of anaphylaxis later on to these foods that you are removing. So because of all these complexities, the guidelines basically suggest that children under the age of 5 with moderate to severe AD, unresponsive to topical therapy, undergo testing for food allergies, including oral food challenges or trials of elimination diets. Of note, clinical care should always start with optimization of skincare and topical therapies regardless. When these efforts are unsuccessful, then testing can be considered. Not everyone with a little bit of eczema needs a food test right away. The risks and benefits of testing and food elimination should be discussed with the family before recommending testing or dietary elimination. And age and atopic disease severity should be taken into account. The benefit may include an improvement in AD, but food removal will not cure AD. The risks include potential development of anaphylaxis and effects on nutrition and quality of life. And I know that over the last three slides, we've been kind of repeating the same because I think this is somewhat of the most important updates that I would like family physicians and pediatricians and others who treat patients with eczema and food allergies should know about before even referring to an allergist. So optimal skincare, what does that mean in eczema? What is optimal skincare? Recommendations used to be not to bathe kids and young adults a lot when they have eczema. And then the recommendations were like, no, you should bathe these kids and adults more than once, maybe for 10 minutes at a time, and really let them soak up all that moisture. And, you know, optimal skincare now includes appropriate bathing recommendations and then immediate use of emollients and topical medications to capture that moisture and keep the skin wet. That's, I think, key. Keep it moisturized. And then if you need to, in more moderate to severe cases, you add wet wraps to that. And then where indicated, you may need systemic medications such as dupilumab and others that we will discuss. Behavioral interventions for itch and sleep should also be part of the plan because diagnosis and treatment of mental health comorbidities often must be addressed when patients have severe eczema. And then always remember that potential evaluation for contact dermatitis should be considered because not always is this an intrinsic atopic dermatitis that for which the trigger cannot be removed. With regard to food allergy, patients with immediate allergic reactions to food should be evaluated for food allergy, and appropriate avoidance diets should be recommended. But again, in the absence of the immediate reactions, appropriate management is more nuanced, and we're still needing more research. So type 2 inflammation in atopic dermatitis. So we know the role of the skin barrier in the development of type 2 inflammation is important. Defects in the integrity and health of the skin barrier provide a route for antigen exposure and sensitization. In addition, the role of microbial diversity, genetic defensive barrier dysfunction, and alterations of epidermal immunity are all important in the development of type 2 inflammation. And Th2 cytokines IL-4, IL-5, and IL-13 are major players here. And this is why some of our biologic agents target these cytokines. There's also an increase in IL-33 in atopic dermatitis. There are, an increase in IL-33 promoting itch and dermatitis. In addition to TSLP and IL-33, there's also epithelial and endothelial cells that can now express IL-25, which has an increased expression in atopic dermatitis, and IL-25 inhibits expression of filaggrin, which is so important in maintaining the integrity of the skin. Additional studies are needed to further understand the interplay between all of this, for sure. So the intensity of management and treatment of AD is dictated by the severity of illness, just like in many conditions, medical conditions, more severe disease has to be treated more intensely. But here it really relates to the effect of AD on the quality of life of these patients and also of their parents and extended families sometimes. Physicians should really establish a treatment goal with the patient before they start treating them. What is the goal? How well do we want to have this controlled? How much is this affecting the patient's physical and mental health? And we want to include in the conversation as one of the major goals, reduction in the number and severity of exacerbations or flares and increasing disease-free periods. We also want a systematic multi-pronged approach that includes all of the list of things here: hydration, topical medications, systemic medications if needed, antibacterials, and eliminating exacerbating factors. Our secret word for my talk is the great William Sherwin. So let's start with simple treatment, skin hydration. The first step in treatment of eczema is always maintaining skin hydration, regardless of how severe the disease is. You're not going to jump to a biologic agent. AD is always characterized by the water loss and dry skin that comes with reduced skin barrier function. Hydration with warm soaking baths for at least 10 minutes, followed by immediate application of good moisturizer, is highly recommended now. To maintain skin hydration, emollient should be applied at least 2 to 3 times per day, and preferably immediately after bathing or hand washing, even if you're doing this multiple times a day, so it maintains that moisture on the skin. And then thick creams, which have a low water content, or ointments are better. And so zero water content with ointments is generally preferred, as they better protect against xerosis. So then you also want to think of avoidance of triggers. So these could be environmental triggers. Definitely, we know that there is a link in some patients with dust mite allergies or cat allergies and eczema, and removing those triggers could help. And then there are some suggestions that pollen allergies can worsen eczema as well. Then we talked about food allergies and food allergens being a trigger in many patients. Emotional stress. Number 4, low humidity environments. When it's very dry, the skin will dry out more quickly. When patients move here, let's say from the Midwest or places on the East Coast where there's a lot of humidity, like Florida, and then they come to Los Angeles, I see a lot of those patients in clinic, and eczema, patients, again, with a predisposition to atopic diseases will present with terrible eczema, and some of them never had eczema. They just had allergic rhinitis, or they had minimal eczema as a kid, and now they have full-blown eczema, and sometimes even nummular eczema, which are they look like coins over the skin, and nummular eczema can be very tough to treat as well. Overheating or over sweating is sometimes a trigger. And then avoidance of triggers like skin infections. So you want to treat those skin infections, is what I meant here under number 6. And then higher susceptibility to both irritant and allergic contact dermatitis. So avoidance of trigger body products. Don't use that certain body wash that you bought, or now what's very popular in a lot of young adult females is using multiple body products from TikTok and social media. And, sometimes their eczema is really triggered by this or worsened by this. And you may even consider patch testing to these chemicals, preservatives and dyes and emollients, etc. But when you do patch testing, there is a higher false positive rate in patients with eczema. First-line therapy after you do the moisturization and all those avoidance strategies is definitely, in mild to moderate eczema, topical steroids when moisturization is not enough. Low-potency steroids are recommended for maintenance therapy, whereas intermediate and high-potency steroids should be used for the treatment of clinical exacerbations over short periods of time. Obviously, you're always avoiding the face and skin folds and wherever skin is thin and the genitoureal areas. You don't want severe or high potency steroids. When prescribing topical steroids, you should always think of the degree of absorption in the skin. So you're also avoiding systemic adverse effects that could happen with continuous use of topical steroids. Of note, we also have some now pretty effective non-steroidal topicals. So topical calcineurin inhibitors do exist and have existed, but we also have PDE4 inhibitors now, which are newer, like Eucrisa or sorry, I can't say the generic crisaborole. We always say Eucrisa, but this is a boron-based small molecule topical PDE4 inhibitor that is FDA approved from the age of 3 months old all the way in adulthood for moderate atopic dermatitis. And Eucrisa 2% ointment is supposed to be applied twice daily to the affected areas, and you want to continue typically for 4 weeks as per the study where it was used for 28 days. But you now often can use it, and it has approval for once a day maintenance therapy. The main thing with Eucrisa is that the adverse effect is significant burning and stinging sometimes at the site of application, but it usually goes away. So when patients have it initially, don't tell them to absolutely stop unless it was really severe stinging and burning. It doesn't damage the skin. It's not actual burning. And, sometimes it is very, very effective. And sometimes mild to moderate eczema definitely can go in remission at times. It's definitely not effective in everyone. The topical calcineurin inhibitors have been around a long time. The ones that are approved here are obviously Protopic or tacrolimus and pimecrolimus or Elidel, and they're very effective and they're completely steroid free. So it is very safe from the age of 2 years for the treatment of AD. With many patients experiencing a significant reduction in itch within a few days of initiation of therapy, and they don't cause the skin atrophy or other corticosteroid-induced adverse effect, even though they're very good immunomodulating agents. Yeah, one thing I wanted to highlight is that theoretical link between the use of topical tacrolimus and pimecrolimus in cancer, particularly lymphoma and non-melanoma skin cancers. This was really based on the cancer risk associated with systemic tacrolimus and systemic immunosuppressive doses. Multiple studies were done afterwards, and really there was no significant risk of cancer and the topical use of tacrolimus and pimecrolimus, but it is still a black box warning in the United States. And I do tell my patients about that very potential slight risk. So the newer topical treatment option for eczema is ruxolitinib or Opzelura, and this is a JAK inhibitor. And this JAK inhibitor was fairly recently approved in September of 2021 for short-term treatment of mild to moderate atopic dermatitis in immunocompetent patients older than 12 years old and whose disease is not controlled with topical prescription therapies that are typical, such as topical steroids, topical calcineurin inhibitors, and the PDE4 options here that we discussed. Topical ruxolitinib is applied twice daily to affected areas of the skin. And if I use this, I only use it a few times. For a few weeks at a time, 2 weeks, 4 weeks. You don't want to do this for a very long time because of possible systemic side effects. Although there's not a whole lot of post-marketing studies, and also there's absolutely no labs that need to be checked with the topical JAK inhibitor use. A significantly higher percentage of patients compared to placebo achieved a 75% reduction in the eczema area and severity index, or EASI 75, and had clinically relevant reduction in pruritus in those patients. And then the adverse effects in about 30% were burning and itching, interestingly, at the application site. And then upper respiratory infection and headache were pretty common as well. And then long-term safety and potential adverse effects due to systemic absorption are still lacking, and therefore there is that black box warning of serious infections. And some of the other JAK inhibitors, systemic side effects that are known when used for rheumatologic conditions and eczema now, but major cardiovascular events, thrombosis, malignancies, and all-cause mortality. There are some ongoing clinical trials for other topicals in AD, mostly topical JAK inhibitors and other PDE4 inhibitors, as well as tyrosine kinase inhibitors. But here, this ruxolitinib or Opzelura, as well as the Eucrisa are really the only other ones that have been approved so far, in addition to the calcineurin inhibitors. So other treatment options for mild AD that are used are antihistamines, vitamin D, and bleach baths. There is limited evidence that these things help. We know that antihistamines only help the pruritus associated with AD, and treatment of AD with topical antihistamines is not recommended due to potential cutaneous sensitization. Even though first generation and sedating antihistamines may be beneficial for patients with disturbed sleep due to the itch, there's really no optimal dosage or length of treatment, and the efficacy of second generation less sedating antihistamines, H1 antihistamines, is really only there when you are treating concurrent urticaria, so hives, not just AD and allergic rhinitis. There is some low-level benefit, proven benefit with vitamin D supplementation if someone has a low level of vitamin D. And then the bleach baths are considered twice weekly to reduce the severity of AD in recurrent skin-infected atopic dermatitis. Patients with persistent moderate to severe disease, despite optimal topical therapy and all those avoidance strategies, should be evaluated for systemic treatment to achieve adequate disease control. But prior to initiation of any systemic therapies with biologic agents, I would recommend excluding concurrent disease or contact dermatitis, etc. The main biologic agents that are FDA approved and used are dupilumab and tralokinumab. Most allergists, immunologists, or dermatologists do know about dupilumab or Dupixent, which is a fully human monoclonal antibody that binds to the alpha subunit of the IL-4 receptor and then inhibits downstream signaling of IL-4 and IL-13, which are the T helper type 2 lymphocyte cytokines that play a key role in atopic disease, including asthma and eczema. Dupilumab is fully FDA approved for the treatment of adults and children aged 6 months only and older with moderate to severe AD that is not adequately controlled with topical prescription therapies. That new indication of 6 months and older is newer, but the drug itself was FDA approved in 2017. And compared with conventional immunosuppressive agents, dupilumab has a much favorable safety profile and may be used for long-term treatment of AD. So you start with subcutaneous injections every 2 to 4 weeks with an initial loading dose that's double the recommended dose, so typically 600 milligrams, and that's then followed by a maintenance dose of 300 milligrams every other week. In children that are young, it's obviously based on body weight, and the full dose is maintained until dermatitis is cleared. Concurrent use of other topical therapies is completely recommended and done. And in patients whose skin has been clear of eczema, we start tapering down dupilumab, even though it's not fully recommended like that. There's actually some studies showing that you can go down, and I often go from every 2 weeks to every 3 weeks or 4 weeks or even less. But if you have an eczema flare, then you can restart dupilumab at that every 2-week frequency again. Post-approval studies have shown that IL-4 and IL-13 blockade does reduce skin infections and S. aureus colonization as well, and improves those atopic comorbidities as well. Some frequent adverse side effects of dupilumab include injection site reactions. Conjunctivitis is a main one. Facial redness and dermatitis, interestingly, sometimes. Eosinophilia happens, but it's typically just a very temporary. And then increased frequency of herpes simplex virus infections rarely have been seen, as well as psoriasis-like eruptions, or potentially even the development of psoriasis during therapy. Reactive arthritis has also been seen. And then in patients who started dupilumab, we have seen some mycosis fungoides cases. And so acceleration or questionably even being the cause of the disease may be a problem here. So in patients at higher risk for mycosis fungoides, so not obviously very young patients, but more middle-aged and older patients, this sometimes should be ruled out if you are suspecting it. A newer biologic agent called tralokinumab, or ADBRI, is another fully human monoclonal anti-IL-13 antibody. It is approved for the treatment of moderate to severe AD that is not adequately controlled with topical prescription therapies in adults in the United States and in adults and adolescents in Europe, but approved in the USA in December of 2021. In adults, tralokinumab is administered subcutaneously with a loading dose of 600 milligrams followed by 300 milligrams every other week. Adverse effects are mainly viral upper respiratory tract infections, conjunctivitis, and injection site reactions. And skin infections requiring systemic treatment occurring with lower frequency in the tralokinumab groups were also seen compared with placebo. So let's talk about JAK inhibitors, because we have that topical JAK inhibitor, right, the Opzelura, that was approved, but also since fairly recently in 2022 or the end of 2021, for the second JAK inhibitor, we now have abrocitinib or Sabinco and Rinvoq or upadacitinib. And these are JAK inhibitors that provide a more rapid improvement in signs and symptoms of AD compared with biologics, because they can suppress multiple immune pathways. The benefit of these is that it's a pill, it's an oral administration versus a subcutaneous. And the problem, though, is that there is a potential risk of associated serious adverse effects, and you always have to look at the risk versus benefit, and that should be assessed. This is usually used when there's no improvement on the safer biologic agents like dupilumab or tralokinumab. And the JAK inhibitors approved in the United States, again, are just the abrocitinib and the upadacitinib, the Sabinco and Rinvoq. Both of them are oral, as you know, and we only use this if not controlled with the other systemic therapies, including the biologics. Abrocitinib or Sabinco is used at an oral dose of 100 milligrams a day, but if there's not significant improvement and they still have severe disease, you can double that dose to 200. In head-to-head trials, interestingly, abrocitinib 100 daily showed efficacy similar to that of dupilumab. And then the second JAK inhibitor, upadacitinib or Rinvoq, this one is 50 milligrams once a day and also can be doubled if the 50 milligrams is not enough. And two randomized controlled trials show that upadacitinib was actually superior to Dupixent or dupilumab. For all these studies, the primary endpoint was the Eczema Area and Severity Index 75 or EASI 75 response. This is when 75% improvement from baseline at 16 weeks of treatment is seen. And, they obviously had a significant improvement. Since the JAK inhibitors have broader immunosuppression, even though it has benefits of greater response to treatment and more rapid improvement, it also means more closer clinical surveillance and close laboratory monitoring, labs that need to be obtained prior to and during treatment. So prior to starting these and then 4 weeks after are definitely a must. And it is a CBC with DIF, it is a CMP baseline lipid panel, as well as hepatitis B and C, TB testing, and screening for HIV. And then long-term studies of the safety of oral JAK inhibitors in patients with AD are completely lacking. The data are more for when these are used in rheumatoid arthritis patients older than 50 years of age and with known cardiovascular events. Other immunosuppressive agents that have been used for a while now, off-label in AD when it's refractory to the FDA-approved options are cyclosporin, methotrexate, azathioprine, and mycophenolate mofetil. And these all have a worse safety profile than the approved biologic agents for atopic dermatitis. Phototherapy is also an option. There's mixed results with that, and dermatologists like doing these. In allergy, we typically do not do any phototherapy. And then allergen immunotherapy, which is obviously the bread and butter. What we do, allergy immunotherapy resets the immune system, and it's really, when given through allergy shots of subcutaneous immunotherapy, it's FDA approved for allergic rhinosinusitis, conjunctivitis, allergic asthma, and there is definitely some benefit in those patients who have sensitization to environmental allergens proven on skin prick testing and IG blood testing, that you can use this in eczema. And I'm often seeing a very, very good response. AIT may be administered either subcutaneously or sublingually. I do sublingual aeroslid or sublingual immunotherapy as well. These do have to be always monitored by an allergist. They have been studies showing that both SCID and SLID do help patients' eczema as well. So I want to end with a quick case here that kind of captures a lot of what we discussed. So I had a patient who's a 32-year-old female with a history of childhood asthma. She outgrew in her teens, who presents to clinic complaining of multiple dry, itchy patches behind her knees, on her face, as well as dry, itchy upper eyelids. She states that the itchy patches and rashes came on after she moved from Connecticut to California last year. She denies any other symptoms except for the itchy, dry patches on her skin. She cannot pinpoint any triggers of her symptoms. She denies any known food allergies whatsoever. She denies any symptoms of allergic rhinitis, no nasal congestion, sneezing, itchy, watery eyes, or any rhinosinusitis symptoms whatsoever. She's used topical corticosteroids as well as tacrolimus with temporary improvement, but symptoms return as soon as she stops the topicals. So she also tried to crisaborole topical ointment BID for 28 days without any improvement. She does state she moisturizes at least twice a day with Aquaphor. She does apply it the way she's supposed to after a 10-minute shower. On exam, she has slightly scaly and erythematous patches in her popliteal fossae, on her bilateral cheeks, as well as dry erythematous skin on her bilateral upper eyelids. So the rashes look like, typical eczema. So what's the best next step in this patient? She is 32. Would you start dupilumab immediately, loading dose, and then 300 every 2 weeks? Or would you do B, allergy skin prick testing to peanuts, soy, sesame, wheat, milk, and eggs? Or would you do C, allergy skin prick testing to environmental allergens? Would you do D, patch testing for contact dermatitis? Would you do E, biopsy of the skin patch to rule out mycosis fungoides? Or would you start abrocitinib, 100 milligrams POQ day, with the option of increasing to 200 milligrams POQ day because it's PO and much easier if there was no significant improvement on the lower dose? So I'm not going to give you the answer today, but I want you to think about this, and we will get back to this when we do our summary slides in Vegas. And here are my references. And this is the end of my talk on some updates on eczema and the treatment. Thank you.